and absolutely thrilled to welcome Dr. Rachel Greig, whom I've worked with for quite some time in a number of ways. And she's going to talk to us about molecular profiling. And she'll also be introducing or launching, I should say, a new brochure for patients and carers, which will explain molecular profiling, particularly for cholangiocarcinoma, and that's something very, very special. So thank you, Rachel, and the floor is yours.
Thank you. I feel more comfortable standing, so I'm going to stand over here, if that's okay. I'll put the water down here. So thank you for the introduction, Helen. As she said, I'm Rachel, and I am the Cholangiocarcinoma Therapy Area Lead at Incyte. As Helen said, she invited me to attend the conference to discuss with you molecular testing in cholangiocarcinoma and also introduce this booklet that Helen and I have been working on this year. So before I go into the main body of my talk, I thought I better set the scene because we're talking about molecular testing, and I just want to make sure that everyone knows what that is before we go into a bit more detail. So molecular testing might be called molecular profiling or genetic testing or genomic testing or even biomarker identification or any combination of those words. And essentially what it is, molecular testing is looking for certain changes at the genetic level of a patient's tumor, okay? And this is important because the more information that a doctor knows about his patient's tumor, and even at a genetic level, it can help the doctor better plan the treatment and how they're going to manage that patient. So what I'm going to talk to you about today, I'm firstly going to introduce an animation that Helen and I worked on last year. Some of you may have seen it already. I'll then talk about the booklet in some more detail and give some more context about some of the topics within the booklet. I'll of course talk about molecular testing and some of its wider significance, and then I'm here to answer any questions. The other thing I will say is if I can't answer them now, I can go away and check, or if you don't think of a question right now, I'll be here for the next few days. So don't be, just feel free to come and grab me and ask me. So the animation was something that, as I said, Helen and I worked on last year. And the aim of the animation was to raise awareness of the importance of molecular testing in cholangiocarcinoma. Now, molecular testing is done as standard in lots of other different types of cancer, for example, lung cancer, but it had never been done in cholangio before. And so we wanted to think of something that was fun and memorable, but also got the message across. And the animation is actually aimed at anyone, really, anyone who cholangiocarcinoma touches. So patients, family members, and especially doctors as well. So I'm going to play that now, or is someone going to play that? Oh, here we go.
My name's Erica. I'm 53. I've got 2 teenagers at home, and one of them has flown the nest. I work in an insurance company. I'm just like anyone else, really. Except I've got cholangiocarcinoma. It's a rare type of liver cancer and one of the toughest ones to treat. My care team reckon I've had it for years. Getting diagnosed was a terrible shock to the system for me, my husband and my kids. I'd had some pains in my stomach, but I didn't think they were serious. By the time I saw an expert, it was too late to operate. A few months ago, I didn't have any real worries, but now my life feels so uncertain. But my doctor tells me things are changing in cholangiocarcinoma, so I'm hopeful about the options that might be available to me.
Cholangiocarcinoma is a very aggressive cancer, and due to a lack of specific symptoms, it's often diagnosed late. This can make it hard to treat, and currently there are very few treatment options available for these patients.
My diagnosis came after a biopsy, like a big injection, except they take tumour tissue out instead of putting medicine in. It was just a small piece of me, but precious and incredibly important. It just may be a key to unlock new options for patients like me.
Molecular testing has become essential in the fight against rare cancers like cholangiocarcinoma. All of us have an increasingly important role to play. from ensuring enough tissue is taken during biopsy to using it sparingly during diagnosis to make sure there's enough left over for molecular testing.
My team were great. They've made that tiny bit of tissue go a long way. And now I'm waiting. If certain genetic changes are found in my cancer, it might make me suitable for new targeted treatments. So, well, fingers crossed.
The cells in our bodies are constantly dividing. Sometimes, when certain genes in the cells change and become faulty, for example, when mutations occur, it can drive the cells to grow out of control. This is how cancer is formed. In order to try to stop the cancer growing, these faulty genes have to be brought under control. This can be done by selecting the right treatment. Almost half of cholangiocarcinoma patients have genetic changes, like FGFR2 fusions, which can potentially be acted upon. Molecular testing helps us to identify patients who have faulty genes in their cancer, and in turn, those who might benefit from targeted therapies that could significantly extend their life. And as more genetic alterations are being explored, we are creating a genetic footprint for the identification and treatment of the cancers of others in the future.
It's been a difficult time for sure. But knowing I might have a way to get a bit more time, that keeps me going. And even if I don't, it's nice how that little part of me has contributed to science. That it might help someone else like me in the future. That's something.
If you've been diagnosed with cholangiocarcinoma, ask your doctor about molecular testing.
Okay, so as you saw within that animation, there was lots of different topics kind of touched on. And what we thought might be useful was to develop a resource, like a companion resource to the animation, to discuss some of those topics in more detail. Now, this is just for those who want it. For some people, it might be enough that they feel that all of the tests that they had as part of their diagnosis were done, and they're not really that interested about the specifics of the different tests. And that's absolutely fine. But for some people, there is a desire to understand more. And that's where the booklet came in. So the booklet discusses topics in a bit more detail from the animation. So looks at genes and cancer. Of course, it talks about the specifics of molecular testing and also treatment targets. There's also a list of questions that patients can use to ask their doctor. So I'm going to talk about some of these themes in a little bit more detail to set the scene of the booklet. So it first starts off talking about the significance of genes in cancer. So as was said in the animation, we have trillions of cells within our bodies. And within each of our cells, we have our DNA. Now, the way DNA is organized is into segments, and these are called genes. So you see this on the diagram here. You see the helix of DNA. The yellow section represents a gene. And that gene is a code that causes the cell to act out its function. For example, making a protein. And this isn't a static system. Our cells are constantly replicating all of the time. And in a perfect universe, the cells would replicate, healthy cells would replicate exactly the same as their parent. But sometimes that doesn't happen, and faults can occur. You see here on the second diagram that there can be small mistakes within the code. You see here there's the red A that has replaced the C. And that is called a mutation. Now, sometimes mutations don't actually matter, and it doesn't make any difference to the cell, and the cell can still perform its functions perfectly normally. But sometimes mutations are more significant, and it can start causing the cell to act strangely. Okay? And when that cell acts strangely, it can start growing out of control or producing an abnormal amount of protein. And this is essentially what cancer is. Now, there's different types of mutations. You can have driver mutations. And this is, as the name suggests, it's a mutation that is driving the cell out of control. You can also have resistance mutations. And these are mutations that are acting to almost protect those faulty cells. They protect those cells from being attacked by cancer treatments. And we can get mutations in different ways. So inherited mutations are mutations that are passed down from one of our parents. And so they may increase our risk of developing certain cancers. An example that might be familiar to you is the BRCA mutation, which increases a person's risk of developing breast cancer. What's actually more common are these things called acquired mutations. And these are just things that act on our bodies all of the time and can cause faults within our genes. Such as an example in the booklet is UV rays from the sun, which can cause faults in the genes of our skin cells, which can increase our risk of developing skin cancer. And so I've spoken to you and shown you that mutations can be a problem. The good news is that we can actually use mutations to our advantage. And more now, cancer treatments are being developed which target cells with those faulty genes. So when you think of chemotherapy basically zaps cancer cells, but it also can impact healthy cells as well. Targeted treatment is, as it says, it's targeted. So it only targets those cells that have the faulty gene. So it's directed to cancer cells. And this is where molecular testing comes in, because the doctors need to find out which patients have those faulty genes, whether they occur and what those genes are, and then it can help the doctor design how to manage the patient's treatment. So what treatment they might get, or whether the patient could be eligible for a clinical trial. So the booklet discusses in more detail what I've just introduced to you now. It then goes on to talk about molecular testing specifically within the NHS, so how it actually works with us here. I will say it's specific to the NHS, but actually the pathways are very similar to what happens in other countries as well. So basically, the flow shows that a piece of biopsy, which again you saw in the animation, is taken from a patient. It's processed, and then it's sent to a specialist lab for analysis. And then they look at trying to identify if that sample has any faulty genes. The report is then sent back to the doctor, who can use that to plan the patient's treatment. The book goes into more detail about biopsy techniques and also the different molecular testing techniques that are available. And the book also discusses some common gene faults that are found in cholangiocarcinoma. The interesting thing within science is more and more we're finding out the significance of genes in cancer, but some genes that are significant in one type of cancer aren't necessarily significant in another. And even within cholangiocarcinoma, different types of cholangiocarcinoma are more likely to have different genes than other types. So for example, genes that you might find in intrahepatic cholangiocarcinoma will be different from gene mutations, gene faults that you find in, say, perihilar or distal. And the important thing to remember about molecular testing, it's not just about whether a patient is suitable for a targeted treatment, it's also about whether a patient is not suitable. And this is important because all cancer medicines can result in side effects and can result in harm. And so you don't want to give a patient a treatment that could cause harm without giving no benefit. And so molecular testing is important for that sense as well. And so with that, I will close. I have lots of these outside, so please help yourself. My plan for this book is to keep it constantly updated. So as science is finding new gene faults that are significant, we will add these to the book. So I will welcome any feedback that you may have as well. And so with that, I'll take any questions.
Well, once again, I'd like to thank Rachel hugely for coming today and explaining about molecular profiling in such a clear way. I feel I want you to do it all again, because I didn't quite, there's so much. Every time I hear about it, I take in another little bit and another little bit. So I think that the brochure is going to be a hugely useful resource for us. And thank you so much for bringing 2 huge boxes full. They are hot off the press. As Rachel said, she does have them for all patients and carers to take, and also all the nurses we have with us here live. Please do take a supply for your patients going forward, because this is very, very useful. We are now going to open to questions for Rachel. If you'd like to come back to the table, Rachel.
Yeah, sure.
And I'd also like to ask Gary to come up and join us to moderate the question time. Please remember, you can submit your questions via the app, whether you're here with us or whether you're virtual, and you can also put your questions from the room. Just raise your hand, and I think it's James or Jamie will come towards you with their well-sanitized microphone. So over to you, Gary, if you have a question for Rachel.
Just very quickly before we go into this Q&A, I just want to reassure those that submitted questions in the previous session. We had several that we were unable to answer, but just speaking with Margaret and Louise, they're going to take the time to respond to those, and that we'll find a way to make them available to those that asked them. So that'll be available at some point after the conference. So we are joined once again by around about 80 people virtually, and we have obviously several people in the room. I know there's a question on table 15. So we'll start with a question in the room before we go to some of the virtual questions.
So I just wanted to ask, if you don't have an actionable mutation, what does that actually mean in kind of patient terms? What does that mean?
So when an actionable mutation kind of means that it's something that you can take action for. So it generally means that you have a mutation that matches a targeted therapy or allows you to be enrolled into a clinical trial. So if you don't have an actionable one, that's what it means, that there's no action that can be taken. But remember I said, that not having an actionable mutation isn't necessarily a bad thing, because it allows you to know which treatments wouldn't work. And so you don't want to give a treatment to someone which could cause harm and not cause benefit.
Could I come in on that? Because I've got a bit of a follow on. That was a really useful question. So if you don't have an actionable mutation, does that actually mean you might have a mutation? I mean, because these reports show endless different codes and things, don't they? But does that mean that there isn't a targeted therapy available now, but you may have a mutation that might be actionable in the future?
Yes.
Yeah.
And I think it's a thing of language, actually, because we talk about actionable mutations. We can also talk about mutations of clinical significance. And sometimes that means there might not be a targeted treatment, but you understand that a particular mutation might mean that a cancer is more aggressive, or it might mean that a cancer is slower growing. And that's important information for a doctor to know as well, because then they can think about, potentially more frequent scans or whatever it is. So yeah, it's like you say, and that was one of the things in the animation when we talk about building a genetic footprint, because now that molecular testing is actually funded as part of the NHS, we're collecting all of this data now, and that's always going to be there. So you can always go back and look at it again, and just keep gaining more intel, basically.
Excellent. So before we go to another question in the room, I'm going to start with a very simple one from the virtual audience. Is there a PDF of the book?
Yes, there is a PDF of the book. It will be, I think it will be uploaded on the AMMF website, but yes, we have that available.
As soon as possible.
Yeah.
So there's a question at table 2, I think. So, table 3. My apologies.
No worries. Hi. So there's a couple of questions here, so we'll see how we get on. But so it targets cells with faulty genes, right? Is some of the aspect of it. But then there will be cancer cells that don't share those same faulty genes, would be my guess. They're not all going to be exactly the same. So kind of 2 questions. Does the cancer constantly mutate, and therefore can it avoid some of the targeted therapies? So, for instance, FGFR2, can it avoid that because there's other cells that can proliferate because they are not FGFR2 in that example? So what's the answer to that?
Yeah, so FGFR, for example, and there's other ones which would be a driver mutation. But, I mentioned earlier, you get these resistant mutations. So sometimes you can have cells that have a driver and then other mutations start popping up. That means that it's protecting the cancer.
So just to follow up on that, then is it possible to do follow-up molecular testing to see changes and therefore any adaptations that it's had, you can treat those as well?
So within cholangiocarcinoma, that doesn't happen at the moment because there's not so many other tests, other treatments, targeted treatments available. But yes, that does happen. And certainly in other cancer types, it's recommended that a patient has molecular testing maybe every 3 months, every 6 months and things. So yes, that does happen because for other cancer types, when there's different combinations of drugs, it's really good to start seeing when resistant mutations are coming because you can action it straight away.
And sorry, last bit.
Yeah.
I promise. And so, obviously if someone's had cancer that is spread, outside of the liver, the biopsy may or may not be possible depending on the size of the tumor. So is it worth doing liquid biopsy beyond that point to see if there's anything that can be done?
Yeah, so it is worth it. I think some tumors, so this is to do with like tumor shedding DNA. And so some tumors shed more DNA into the blood. And actually cholangiocarcinoma is one of those. So liquid biopsy is actually quite a good one to use within cholangiocarcinoma.
Thank you.
Yeah.
Could you just describe, for those who don't know, what liquid biopsy is, what that actually means?
Yeah, of course. So you saw in the animation, and I mentioned when a patient has a biopsy, basically what that is taking out a piece of tissue which has tumor within it. So that's a solid biopsy. A liquid biopsy is essentially a blood test. And so you're trying to get tumor DNA from the blood rather than the solid part of the tumor. So yeah, liquid is the blood.
Yeah, and that is becoming more sensitive,
yes,
it?
More and more. I think that's one of these more and more. There's a lot of research going into that. I think, as many of you will know, cholangiocarcinoma can be a bit of a problem because sometimes the position of the tumor means it's very difficult to get the biopsy. And so liquid biopsy is a really good plan B for when you can actually get that solid tumor. And so it's not available on the NHS now, but it is available as part of clinical trials. And often different hospitals within the NHS have access to it on a research in a research way.
Always worth asking about that.
Definitely, yeah.
So just as a couple of very similar questions that have come in, just to follow up on that very good question. So can molecular testing still be useful if surgery has been performed and a patient is currently no evidence of disease, to be ready if a reoccurrence was to happen?
Yes, it can. It certainly can. I think if the surgery has removed the tumor, then they will have that tumor saved, if you like. They'll be processed and saved. So molecular testing could be used. The turnaround time for molecular testing should only be maybe a couple of weeks. And so I would say that whilst it could be done, it's maybe less urgent because there would be time. And also because it's related to targeted treatments, some of the target treatments that are available are kind of given to patients later on. So if a patient really wanted it, they could talk to their doctor about having it, certainly.
Thank you. So we've probably got room for two more questions at table 5 from the room, if that's possible, please.
What are the most common causes of the acquired mutations with specific cholangiocarcinoma?
I don't think that we know this.
No.
Yeah, I don't think we know. There's so many different things that can cause all different types of cancer. And I think, I know there's certain ones that maybe are likely to impact on wider liver cancers, potentially alcohol, for example. But also, I think it's one of these kind of really horrible ones that we don't have much explanation for, and it develops.
Thank you. So we've probably got time for one more question. And I just want to... So the question, I think a good question to ask here in this session is, currently do all patients with suspected cholangiocarcinoma also have molecular profiling, or is it done after diagnosis?
It's done after diagnosis.
That was quick, so quick.
Yeah.
What we've got, so a good question, just sort of quite broad though, is are other cancers further along the development process in molecular profiling?
So I wouldn't say they're further along the development process, because the way that molecular profiling is done in cholangio is the same as it's done in lung cancer or any others. We probably, I think as a scientific community, there's probably more known about how genetics impact other cancers compared to cholangio, but the testing is the same.
Excellent. My timing's wrong, so we've actually got time for a few more questions. So sorry to put you on the spot.
We are a little behind, actually.
Yeah, I think we've got time for a couple more questions.
Do you think we're behind, Helen?
Well, 16:40 was the next presentation timing.
Then my watch is wrong.
Yeah.
We could talk about this all afternoon. I'm
we haven't
happy
got
to,
time.
but we are actually over
Then my
time.
watch is wrong. Well, in that case, I will definitely. But once again, I think there are lots of questions that have come in.
Well, we were going to go on to similar presentations, but very much geared towards the clinical nurse specialist rather than the patient. So, but that doesn't stop people putting in more questions, and we can come back to those on the molecular profiling. But sorry to step in and
No, thank you.
burst your bubble on the questions. But we are.
Yeah.
But that is, hearing what Rachel has told us this afternoon, it is one of the most exciting things that's happened in cholangiocarcinoma over many, many years. And unfortunately, as you know only too well, there hasn't been much. But this is of huge importance. The fact that we can run molecular profiling, and we can see if there's something that can be actioned, that can be targeted. And we are learning more and more about targeted therapies. And we do already now have one approved in most of the world, I think. And that does mean, and most importantly, that's opened the door to molecular profiling for all those diagnosed with cholangiocarcinoma. So huge thanks again, Rachel, for that really informative talk and for the brochure. Thank you very much. Thank you.